Besides Dr. McCarthy, one of my favorite doctors.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using an inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Okay. So we don't have a Dr. House in our clinic, but we do understand as the CF team that sometimes we have to get down to the bottom of things, and just merely going, are your medications exactly the same, isn't quite enough, because maybe medications being the same was I wasn't taking any of them. And so we do have to, based on protocol by our organization, good practice, good medical practice, there's things we have to do. But during a normal visit right now in clinic, you have vital signs, PFTs, you see the CF team, do a thorough review of meds, thorough review of systems, maybe more than once, see the doctor, go for testing, and that's all, crammed into a lovely 3 to 4 hour time period. Woohoo! Thank you for that. So some of the challenges, and I just came up, I certainly didn't send out like a survey, but this is stuff I hear from people. It's a lot of time commitment to come to clinic. The foundation recommends every quarter minimum, right? So that's if you're just doing well. So many people to see. Some of you in the room will remember when we all sat around the table and talked, and we missed those days. I mean, there was a lot of cool stuff that happened when we could sit around the table because Judy didn't have to ask a question, then me ask a question. We all could hear it. We all could ask once. But infection control, rooms, sizes, there's various things that got taken away as an option. New problems come up. I mean, that's a huge problem or a huge issue for families and patients. So you come and then, ta-da, we just gave you a new diagnosis, or you have a new problem, and I know that creates a lot of stress. That what if this is the visit, we're going to hear something else that's wrong or something else we have to do. On top of that, maybe there is some bad news. Maybe new medication regimen is going to be recommended, and you have to figure out how to add it to your day, kind of like Brian was saying, yay, another thing to do. You're trying to pay attention and you have maybe your own child, maybe the child with CF is distracting you, maybe you're the adult with CF and you have children with you. So just distractions, and then walking away thinking, how am I going to do all of this? I know what the ideal world is, I know what the perfect scenario is, but how is that going to look like in real life? And then, and you want me to come back in 2 weeks? Okay, that's, more co-pays, more time off work, money, money, money. So it goes down the line of stresses. Some others, throat culture. I'm not the most favorite person in clinic, unfortunately. I know Amanda, some people don't like PFTs, but most of the time people really like Amanda, and Judy gives stickers, and I shove things down throats. So I try to bribe with toys and popsicles, but I still have children that see me coming, and they're like, So that's stressful not only for you as a parent, but obviously for your child. Sputum cultures. I have a lot of adults that hate coughing up mucus, and especially not in front of people, and especially not into a cup to be paraded around. So maybe they don't have to be choked with a culture, but nobody enjoys that. Sometimes, and I would hope not many people in this room do this, but I know it's a reality, sometimes CF is put on the back burner until you have to come to clinic. And then it's like, oh yeah, and I think I can empathize that it must be a humongous challenge to try to live life to the fullest and know that CF is there and not have it overtake, but not completely be in denial either. And I think that balance can be extremely difficult. What if we say you should probably go in and be hospitalized, and that was not on the family schedule, and it was not on your work schedule? Disappointment, I mean, that can just be from all of the above. And then too much at one time, I forgot that word. Sometimes it's just overwhelming, and I know several of you have talked to me, especially that new diagnosis, the first, 2 years of visits was like, I heard nothing, because it's just like so much information. So that's the challenges I know all of you face, and I'm sure there's plenty more that I didn't cover. So then just to kind of maybe put the shoe on the other foot, is what are the challenges that the team faces at a clinic visit. So we have CF Clinic 2 days a week now. Not just one, but 2 still doesn't feel like enough for most of us. I would say the team feels like we only get to see people 2 days a week, and some of our team only work 2 days a week. And even though 180 patients doesn't seem like a huge practice when you look at other practices that may have thousands, CF is a very complicated disease, and we do strive to individualize it. So to individualize care for 180 patients with only 2 days a week is a major challenge. We have unexpected situations. Many of you have been in the waiting room or in the exam room and we're like, sorry, we're so late, we had an unexpected admission. We think we know what the day is going to look like, and then we have these, oh, okay, change of plan things. Infection control, it is a wonderful thing and it is a nightmare all at the same time, and I know you guys share that sentiment. I mean, we look gorgeous in our yellow gowns, but it makes it a real challenge to not just be able to grab and pull and talk in the waiting room, and there's one team, there's only one of me, one of Judy, believe me, we've looked into cloning, it has been examined, but we have 3 providers. And so even though Dr. Chavez may only see a certain amount of patient in a day, that's probably double for the team, as Dr. Wright, Dr. McCarthy also have a schedule. So what about out-of-town patients? We're dealing with, we get a culture while you're there, but now we're having to do follow-up over the phone, which I know is a challenge not only for you, but also for us. To deal with nutritional issues or start a new complicated medicine over the phone is a real challenge, and a lot of times we feel like we're not doing it justice. Educate versus overwhelm. We have so much to share, as you can see by our back tables. I mean, our vendors and all the different support things we have from the foundation means we've got a lot of stuff to give you, but when is too much, and when do we need to do it? And that we feel like we walk a balance there. Support versus being big brother. So when we do go over meds or we ask about airway clearance, we really don't want to be big brother, and we don't want to come off as like, are you doing your stuff? Are you, because that's truly like the house video. We're just wanting to understand how things are being done, if they're being done, because that makes a difference. If something's not being done at all, maybe we can just reinstitute that versus being hospitalized. And so that honesty isn't about us judgmental or anything. It's really just getting to the bottom. But sometimes it can come across as big brother judgmental, and we don't want that. And then how do we personalize each visit? We want every visit to meet your specific need in that time. And with all the things above, that can be a challenge. So what do we do with this? So we have your challenges, our challenges, and how do we marry them together? And I think when I go to big conferences with CF, this is the question all of the coordinators and teams are asking is how do we do this better? Well, I think the biggest thing that makes it better is looking at all of us as a big team in this. It's not us versus you. It's not you versus us. We're all on the same side of this. And so, and part of it is the culture of medicine is changing. It's slow, but it's changing, and we're really trying to change faster than the general culture is looking. You guys, whether you're the patient, whether you're the parent, whether you're the spouse, the grandparent, you're part of the care team just as much, if not more so, than anybody else that is on salary with Providence or at the home health. You are the main part of the care team, and what you say and what you feel and what you know absolutely matters. Also what matters and what can be helpful is knowing what you want out of the care. Because I think sometimes from the medical side of it, we know what outcomes, we know what FEV1s we're going for, we know what BMI percentages we want. We have these numbers and these metrics that we are going for. But that's not how daily life works. I don't live that way with my doctor. What are my goals? Well, my goal is to be active with my kids. My goals is to be able to do the things I love and achieve the things I love. And I know all of you are no different. So I think sometimes it's maybe even maybe fixing our wording to not, are you meeting certain goals, number-wise, health-wise, but how can we help you live the life you want? And so if your daughter is a gymnast, then her goal maybe is not as much doing my Pulmozyme and my best so I can impress my team or get certain FEV1 scores. Her goal should be, I should do my treatments to be the best gymnast I can be, and how can we help? Maybe we can problem solve timing. I mean, I just talked to Deanna about how do we get to Cub Scout camp with all the treatments. It takes some problem solving, and it takes some being creative, and it takes some, but that's what we want to do, is whatever your goal is. And so I think we just have to change our conversations a little. But also I would encourage you is think about things that you want, whether it's your child, yourself. What are the goals? What are you wanting to do? Because really, that's really what's going to drive you. It's not meeting a certain FEV1 necessarily. So, so I would just encourage you before your next visit, think about what are the things that are important to us. Is it that we want to be able to camp as a family or ride at the Princess Pedal Fest or whatever? I mean, what are the goals, and then how can we help support your health so you can be the most successful? Knowing your needs ahead of time, and those kind of things are if you know you need notes for work or travel or certain refills. Thinking about that ahead of time really helps, and I'll talk about some things about how we can improve that communication. If you know that labs are due, getting them before your visit does help, because like I said, as a team and as providers, that one-on-one discussion of lab results and things is much nicer done in person, especially if there's going to be things we have to change, because over the phone we can't see the facial expressions or the frustrations or whatever, and so that in person really, really helps. And then I would just encourage, and I would say I look out here, and this is not a problem for this group, so I'm speaking to the choir here, but communication more than just at clinic. You know, I have a lot of times where I haven't seen people for 3 or 4 months, and they say, well, I never got that med or that equipment. And I would say, then let me know, like, we are here, and so I'd encourage, but we also need to be more available to you. So we are looking at ways at texting and emailing and having other methods of communication, because sometimes the phone tree is not pleasant, and we all work, and it's hard to call during normal business hours. So those are some ways, or that's some ways we can maybe improve things, but some ways to achieve that. One thing we're going to start implementing is a pre-clinic questionnaire. Initially, this will probably be for people that have MyChart, and then we'll look at rolling it out to people that don't. But essentially, it's a very short little, and it's not like you have to answer every question, but it'll be questions like, what do you want out of this visit, and what specific things do you want to discuss and go over? Do you have any current issues that you've been wanting to talk to the provider about? Are there goals? Are there things we can help you with? And do you need anything? So my goal is to get those sent out a few days ahead of time, so we can just be more prepared for your visit. And then we also, if you have a binder, education binder that we've been handing out, it's in there, but if you don't, we're happy to give you one. There are some, Baylor came out with a parent education system, and one of them was a quarterly visit form. Filling that out can be helpful. It's those questions that pop up a month and a half before your next visit. Some people have found that keeping a calendar or a journal of symptoms or treatments, especially if you're on alternating months of something, or maybe you have a primary care that treats you a lot, and writing down when you went on antibiotics getting labs done ahead of time. And I think really asking questions, or writing down the questions before you come, because I don't know if you're like me, but I mean, I go to my primary care, and I've thought on the drive over about 15 things, and when they say, is there anything else I can help you with? I'm like, nope, and then, oh. So writing it down really helps, and I will take my own advice, I promise. Also, that frequent communication. So thinking outside the box. We don't just have to do the phone call thing. We have my chart. If you're not signed up, we'd be happy to do that. Again, I love email, and we can email securely in the Providence system, and I'm happy to do that. We've been able to start texting, so if that's something you'd like to do and it's more beneficial for you, let me know. We can set that up. And then also, we're working towards more virtual options. So we're streaming this, but we're looking, telemedicine is kind of the wave of the future, and we're looking at ways to start providing that as an option, not necessarily at this point to replace a clinic visit, but say you just had to start Cayston. Anyone remember the humongous box you got when you first started Cayston? It's like, oh my goodness. But maybe Amanda could virtually go over that with you, or the first time you have, who knows? I mean, we're looking at options so that way, especially when you don't live 5 minutes away, we can have interactions. But on that is that if we're doing referrals, medications, and equipment at visit, and you never heard a follow-up, you never got a call, please let us know, because we won't know, really. And our assumption is that you did get an appointment scheduled, or you did get that important piece of equipment. And we don't want to wait 3 months, because usually the reason the provider's ordering it is because it is needed. So feel free to let us know. And even questions and concerns, you are certainly not ever a bother. And I always have, and you guys are very sweet. Oh, I'm so sorry to bother you. It's job security, so please call me, because I love my job. I don't want to be let go because I'm bored. So, but this is what I do, and this is what the team does. And even though the team might not be there every single day, they love to be putting their professional experience to work. So please, make us work a little bit. Insurance issues, I know that was a big issue before when our social worker only worked like 1 day a week. But, and I'm the biggest fan of Oscar right now. I'm like, I have my own fan club. But having him 5 days a week in the clinic has been, I mean, it really has changed that role, and he has changed the role as what it can provide. So if you have insurance questions, let us know. Don't wait till the next clinic visit. If you're paying more than $10, $20 for a copay for a medicine, you should be talking to him. There are a lot of options in the CF world for support and coverage, and again, you're never a bother, you're keeping him employed, and we want to help you. So reach out, and he has been finding ways to support you didn't even know you need to be supported. I promise you, he will find this like, I have a thing for you. So test him on that. At the end of the visit, you all get the AVS, that's the after visit summary. It is something that the federal government mandates we give you, but we want you to have it because it has good information. It has the provider's recommendations from the visit, a medication list. I mean, there's a whole host of things that are in there, and you can access it via MyChart as well. But I would use that. Put it in your binder, take it to other visits, because it already has your med list there. It's updated every single time you come in. So I would say use that as a tool. If you don't remember what Dr. Chavez or Dr. McCarthy said, pull that AVS out, look it up on MyChart, or call us. Because we'd rather remind you what was the plan than for you to feel like, oh my gosh, I was overwhelmed. I don't really know what was going on, and now I'm not sure what to do. We are starting a quarterly newsletter. I don't know that I brought them, but I will be emailing them out, and then we'll have them in clinic. We want to have just once a quarter some little tidbits that we think would be helpful for you to know, and of course the education binders I think have not only useful information in them currently, but the goal is to add to them and have them be something that you can use to help. And then the advisory panel and email group we've already talked about. Even if you're not going to, you can't, or it's not a good time to participate, even if you have feedback you want to give to me that I then can present, or to Rebecca. As you hear all of the stuff that's being said today and as we go on, if you have feedback, we want to hear. We really, really can't improve or do better without your input, because we're coming from the medical side, and even though, you know, we all have a passion for this and we love you guys so much, we're not in your shoes, and you are the best people to give us advice. So we want to hear it, and we'd really encourage it. So that was just kind of that in a nutshell, and thank you. So the next speaker we have is Dr. Chavez, and she's going to be speaking about, yes, thank you. Infections, always a favorite topic. I know I gave her one of the hardest ones.
Hi, good afternoon. I appreciate the opportunity to come and talk to everybody, even though I do have a kind of a difficult topic. But it's not difficult because of it being hard to understand. I think it's just difficult because it makes our lives and your lives more complicated. We're going to talk about what the term eradication means in the context of cystic fibrosis. There's a lot of words out there that have a different meaning in the context of cystic fibrosis. I was thinking of fat. You know, most people think whenever they hear the word fat, it's a negative connotation, but in cystic fibrosis, it's actually a good thing. You know, we want to include healthy fats. We want to be at least at the 50th percentile of BMI. So the same thing with eradication. It's probably, this talk may give you a little bit of a different thought in your head whenever you hear it. So let's see, if Dr. McCarthy figured out how to work this thing, I think I can too. So yeah, so this talk was actually put together by the Johns Hopkins group, and along with the slides there is a couple of videos that we're going to watch. But the problem with cystic fibrosis, as Dr. McCarthy was mentioning earlier, is that there is very thick mucus that doesn't allow the cilia to move. And is there a mouse up here? Or I could use this. Okay. Here we go. This is not a cartoon movie like he had shown you in his slides, but this is an actual electron microscopy slide of somebody's airway. And this is a normal airway. You could, right here are the cells. And all of these broken things are actually only broken because of the way the slide was made, but they're all hair-like structures called the cilia, and those were the ones that were constantly moving and moving the mucus. In the airway of cystic fibrosis, this is literally what happens. So this is the mucus layer, and it's squishing down the cilia, so the cilia can't move very well. And bacteria enjoy living in that nice, humid, warm environment that is just perfect for bacteria to grow, and specific that Pseudomonas bacteria, and that's what we're going to concentrate on mostly in this talk. Here is another electron, or this is a regular micrograph of a airway, and it's hollow inside, it has air. This is the similar part of the airway in a person with cystic fibrosis, and it's full of mucus inside. It's not hollow, there's no air inside. And what happens over time is that a smooth pink airway like this turns into a very inflamed, friable airway. And whenever that is present for years and years and years, that's when you get irreversible scarring that is called bronchiectasis. And that is the whole purpose of airway clearance, is to try to prevent airways from looking like that. Let's see, how do I forward? There it is. I think it's going to do like 3 in a row because I've been pressing so many buttons. But this is a picture of the Pseudomonas. To me, it reminds me of a little hot dog, but it has a tail at the end, which is the brighter green parts of the slide that you can see here. And that tail actually helps it to move. Over time, and we'll see a picture of this in the next slide, over time, the Pseudomonas tail falls off and it just stays stationary in that nice bed of mucus that we were looking at before. And Pseudomonas is actually found everywhere. There's no way of getting rid of it in your home, in the environment, because it's just everywhere. It's not feasible for us to get rid of it in the environment, so what we're stuck doing is trying to get rid of it in the airways of people who have it in there. If you went to the mall and you started doing throat cultures on people at the mall, about 10 to 15% of people would actually culture the Pseudomonas, but if you culture those same people the next day, it'd be gone. In other words, whenever you have normal airways, you could get rid of that Pseudomonas. But in people who don't have that normal ciliary clearance, they are the ones that the Pseudomonas likes to live in there, in the airways. So, I don't know what I'm doing or not.
Is this the arrow on the arrow button?
That's what I've been pressing. Yeah, I think I think maybe my finger's cold or something. So, Pseudomonas, and like I told you, it could lose the little tail, and this is a photograph of little Pseudomonas colonies. You could see the individual bacteria, and they are protected by an extra mucus that the Pseudomonas itself makes. So it reminds me of, have you watched The Incredibles and the big sister, how she can make this kind of force field around things and then things bounce off of it? That's exactly what the Pseudomonas is doing. It creates a force field, so to speak, so that antibiotics or the immune system cells of the person it's living with can penetrate it and kill the Pseudomonas. And this happens only over time. It doesn't happen right away. Maybe with 2 hands. These slides build on themselves. This is the natural history of Pseudomonas inside a person with cystic fibrosis. So a baby is born with cystic fibrosis, and they have an altered mechanism of getting rid of bacteria, so they have a host defense defect. They get Pseudomonas from the environment for the very first time, and we're able to get rid of it, but then it happens that they continue to get it, and eventually the bacteria adapt, and that's when persistent infection occurs. So we have this window of opportunity whenever there's that intermittent infection to actually eradicate the Pseudomonas, and that's what we mean by eradication therapy. And then once we have decided that it meets the criteria for a persistent infection, that's when we start chronic therapy, and here comes that every other month tobramycin or every other month Caistin therapy. So this is another way of explaining the same information. This is a graph that you can walk to from the left to the right. Here's so now it's too sensitive. Okay, so somebody who has never had Pseudomonas, they get their first time of Pseudomonas. We try to eradicate it with an antibiotic, and then if that is successful, they have another period of being Pseudomonas free until the next Pseudomonas comes back. Okay, there we go. And we continue this pattern until at some point we decide that it becomes chronic, and we're not going to go back to that other side. In the one with the very cute little baby, the babies who can't, produce sputum, what we have to do is do a throat culture, and that's the big reason for doing throat cultures every time that you come into the doctor, at least on a quarterly basis. And that is recommended by the Cystic Fibrosis Foundation. That's not something we made up in Spokane. It's recommended because of this window of opportunity. What happens if you don't treat the Pseudomonas? Let me skip that one just for lack of time. And we'll answer my question of what happens if you don't treat it in just a little bit. But this is a slide that makes the point that Pseudomonas likes to live in warm and wet climates. And whenever you look at a map of the United States and where Pseudomonas likes to live, it is in warmer and wetter climates. So that is one thing that is good about Spokane, is that it's a relatively drier climate. But it's still something that we have to manage here, even in Spokane. So in the kind of the handbook on how to treat cystic fibrosis, this statement sticks out. One of the keys to successful management of cystic fibrosis is to prevent infection with Pseudomonas. And the reason that it's so important in the context of cystic fibrosis, and I think I missed the slide, so I'm just going to go ahead and talk about it, is because people who have cystic fibrosis, the number of times that they have to be hospitalized and have to be on antibiotics drops. It's very interesting. FEV1, over a 5-year period when they studied it, it didn't drop even with the Pseudomonas, the new Pseudomonas infection. But the times that that person had to be on antibiotics did increase it. And lifespan overall is shortened whenever you have a chronic infection with Pseudomonas. So it's one organism that has very clear evidence that if the person has it, they're going to have lung function decline. So we target that organism more so than any of the other organisms like MRSA that Dr. McCarthy spoke about earlier, and others that I'll mention in here. So this is a small video on a, I think it was based on a true situation, but it's a doctor from Johns Hopkins talking to one of his patients about their first time that their child grows Pseudomonas.
This is Marianne and a 3-year-old son, Daniel. Daniel's been my patient since he was an infant. He was diagnosed by newborn screening. He has 2 copies of the F508del CFTR mutations. Overall, he's doing well. Today is not Daniel's regularly scheduled appointment. I've asked Marianne to bring him in sooner because his last airway culture was Pseudomonas aeruginosa.
How did he get this infection?
We don't know exactly where he got the Pseudomonas. It's very common in the environment. About 80% of kids or adults with CF will eventually become colonized with Pseudomonas. And oftentimes we find it on routine cultures when we come to clinic.
How do we know Daniel has it?
Well, we get a culture at every visit. And the last throat culture that he had was Pseudomonas.
You said that it was in his throat, but isn't Pseudomonas a lung infection?
You're right. We do a throat culture at every visit, and the culture that we did last clinic visit was Pseudomonas. You can't be 100% sure that it's in his lungs because the throat culture is not a perfect representation of what's growing in his lungs. But it gives you a good idea of what's growing there.
Should we do more testing?
You could do additional tests. We could do a bronchoscopy, look down his lungs, and get cultures of the mucus from his lungs, and see if the Pseudomonas is there. But that's an invasive procedure. And since he's not really having any symptoms, I prefer not to do that at this point.
But he doesn't seem sick.
He doesn't, and that's a good thing. The fact that likely it doesn't have any symptoms means it's more likely that we can eradicate the bacteria. By treating the Pseudomonas early, we have a better chance of getting rid of it. As Pseudomonas stays in the lung, it develops a biofilm coating, so we'll try to get rid of it by using inhaled antibiotics.
What do you mean try?
Pseudomonas is not always clear when we do therapy, so it's possible that we won't be able to get rid of it, but oftentimes we do. After eradication, though, the Pseudomonas can come back again, and oftentimes does.
If it will come back, why begin treatment now?
Well, it's important to treat early. There's a lot of research telling us that the longer we can put off chronic infection, the healthier as long as we be. So it's important to try to treat now, get rid of the infection, and prevent it from coming back in the future. So the first question we need to ask is, should we do eradication therapy?
So what do you think the answer to that is? Yeah, and that is one of very few things in medicine are that clear cut. That yes, we do need to try to get rid of the Pseudomonas in the lungs of a person with cystic fibrosis. So I guess I hadn't skipped the slides about why we need to get rid of it, but in this slide they make the point that before we knew that Pseudomonas was such a bad organism, infection was associated with a 2.6-fold increase in mortality. And finally somebody figured out that if you got rid of the Pseudomonas, that people would live longer. This is a study from Copenhagen, and it was published in 2008 that gave us more information on the support of trying to get rid of Pseudomonas. So on this graph, what they have is years on the x-axis here, and then the proportion without chronic infection of the Pseudomonas on here. So at the very beginning of the study, 100% of patients did not have the Pseudomonas. And whenever they initiated this eradication protocol, or trying to get rid of the Pseudomonas every time that they caught it, they were able to keep the number of people who had Pseudomonas at about 80%. Whereas if they weren't doing the eradication protocol, that number probably would have been down like at 10% of people that did not have Pseudomonas. Does that make sense? So eradication works. That's what that study showed us. So this is what I was thinking about before when I was talking to you about why we want to get rid of the Pseudomonas. So whenever they looked at children who they were trying to keep, free of Pseudomonas, compared to those that continued to have Pseudomonas, they had very similar FEV1, height, and weight. And as you guys know now, those are parameters that we look at to measure how well the person is doing. However, in general, whenever somebody has persistent Pseudomonas infection, they have a higher number of hospitalizations, higher number of needing antibiotics. And just in general, their overall health, how they feel, is not as great. So the Cystic Fibrosis Foundation puts out different guidelines for all the centers in the United States, and even some international centers use the North American Cystic Fibrosis Foundation guidelines. And in 2014, they outlined exactly the pros and cons, and they looked at all of the studies that have been done around this topic of Pseudomonas eradication. And what they recommend is that there is a lot of evidence, they gave it a very high grade of evidence, that inhaled antibiotic therapy for the treatment of either initial or new growth of Pseudomonas from airways is beneficial and should be done. And what they recommended, this was 2 years ago, was tobramycin, 300 milligrams twice daily for 28 days. And I remember very clearly going through exactly the same slide set and the same videos at the Cystic Fibrosis Foundation back in 2000, during the meeting in 2014, and nobody made much of an issue about this statement because at that point, as Streonam inhaled was not as commonplace as it is now. But I think if they were to update it and write it now, the